Good afternoon, everyone. I'm Doug Wood, and on behalf of the members of Innovation and Design Services and the Kern Center, welcome to another in our series of unexpected conversations. In our research over the years, we have repeatedly learned that many of us in healthcare have a way that we can listen but not hear, that we can observe and not see. We have difficulty dealing with people because we tend to see them in the context of disease and not in the context of a person in the midst of health. And as we have observed people in their health journeys over the years, we've learned that it's extremely important that we start from a deep understanding of people as they are, and that people do not wish to be defined by their disease. We've also learned that it is difficult to earn trust and understanding. And sometimes in design we say that we work hard to make the invisible visible. And it is in that sense that I think about this conversation we're about to have today with a remarkable young social worker who will help us to develop a deeper understanding of people by guiding us in a process of understanding bias and ultimately using experiences in the concerns of the transgender community to help emphasize those lessons. Charlie's own healthcare experiences, as well as those that he has gained in his practice as a social worker and his research, will certainly give us some powerful insights into those social transitions and challenges and inequities that are confronted by many people in the United States in their interaction with us in the healthcare delivery system. And he will, I am quite confident, give us a better way to think about how it is that we should deal with people in the context of their lives and their health rather than in the context of a disease-based delivery system. Well, I think you'll find this conversation quite remarkable. Just a little more background about Charlie. He's completing his work on a master's degree in social work with a concentration in health practice at the University of Washington. His research and practice has included work with diverse patient communities, ranging from children to families to those suffering with chronic illness to those who are at the end of their lives and who are contemplating how to manage their health through palliative care. He is an insightful researcher as well and has assumed an extremely important role as the lead director of the TransYouth Project, which is the largest and the first large-scale national longitudinal study of socially transitioned transgender children that will require years of work and effort. And having met him briefly this morning, I know that this project will come to fruition with great success based on his energy and leadership. He has already, in his young career, earned quite significant recognition as a valued researcher and practitioner, emphasizing patient and provider co-creation of health solutions that achieve better health and alleviate inequities in health. And so it is, for me, a great privilege to introduce to you Charlie Blotner. Please join me in a warm welcome for Charlie.
Good afternoon, and thank you all for having me today. So, I'm a social worker, and oftentimes I make this joke with colleagues back in the Pacific Northwest about the social work sweater. And what the social work sweater is how no matter what we're actually wearing, we're always kind of wearing this social work sweater. And if you think about how social workers are portrayed on TV or in movies, usually they're wearing this really comfy, oversized gray cardigan of sorts. And that cardigan would be really cozy if you were wearing it, right? And typically, the conversations that social workers are having on a regular basis are kind of uncomfortable, right? And so it's oftentimes the job of social workers to explain things to folks or to engage in conversations that folks are kind of not so comfortable with. So when I say that I'm wearing the social work sweater today, I say that I'm kind of wearing my sweater that makes me feel comfortable because I know that I might be engaging in a conversation where I might be providing resources or terminology or talking about things where folks might be wanting to learn more resources about a topic that might be new to some, but I'm making sure that I'm kind of comfortable in this process. So today I'm going to be talking as both a patient and a provider. And so even though I'm kind of sharing these two different perspectives, they're both really the same voice. And when I first thought about what it would mean to be transgender, one of my biggest concerns was really about my health. And now, today especially, that's really the biggest concern more than ever. So what we're going to be talking about today is kind of these workplace peer-to-peer interactions and gender bias within that context, and how our socialization shapes so much of who we are. And then we're going to kind of move through trans health in history and present day today. And most importantly, we're going to be talking about opportunities for both patients and providers to work together through research opportunities and in health practice. So why do we care about gender? Why am I here talking about gender today? Well, one of the first things that people often ask someone when they find out that they're pregnant is it a boy or is it a girl? And people get pretty creative in the way that they tell us the answer to that question. You know, you have a gender reveal party, you accidentally start a wildfire, you get a bill for $8 million, it happens. There's a pretty common misconception that most trans people know what their gender identity is from a very young age, when that's not always the case. We have to think about geographic location, access to language, and safety. So I think about someone who grew up in rural Nebraska and never even heard the word transgender until they were 60 years old. I think about the teen growing up in foster care who, if they came out, would be kicked out of their home. And then I think about the youth who certainly did know their gender when they were 4 or 5. And then I think about those who just aren't sure. So children's concepts of gender gradually form between the ages of 3 and 5. And it's in that time period where we also start to see this concept of intergroup play and gender stereotyped activities come out, where we start to want to spend time with people who look like us in this in-group bias and spend time with people who are like us. And this doesn't stop when we get older either. But we can't talk about gender without talking about gender bias. And we can't talk about gender bias without talking about race, without talking about disability, class, citizenship status, size, and more. And there are layers to this. So I recently learned about this app called All AI, and I thought it was pretty neat. So what this app does is it takes a kind of sample of everyone's voice at the beginning of the meeting, and then what it does is at the end of the meeting, it tells you how much everyone's talking, and it tells you the tone of their voice. And so what I learned is that when men and women in this binary sense collaborate to solve a problem, say in a meeting, men speak up at least 25% less than men do. And that's a serious problem, right? But there are reasons why this happens. And so what this app does is it analyzes the pitch or the tone of the voice. And so it might tell you that someone sounds more confident, that someone sounds a little bit more nervous. And we can't really just talk about the reasons why people might be more confident or more nervous without talking about the layers to it. Because just because someone's speaking up doesn't mean that people are listening. For those of us on Twitter, the hashtags like Black Women in Medicine, I Look Like a Surgeon, Women in Medicine, Girl Med Twitter, Black Men in Medicine, these wouldn't exist if there wasn't gender bias and racial inequities where women were presumed to be nurses, or where people of color were mistaken for cleaning staff, right? I don't know how many of you heard the story about Dr. Fatima Cody earlier this month, but she's a physician from Stanford, and she volunteered to assist a fellow passenger on a flight when the person was in distress. And what happened was, when she got up out of her seat to help this fellow passenger, she was immediately questioned, "Are you a doctor? Are you really a doctor? Are you sure? Let me see your medical license. I really don't believe you're a doctor." And, she was questioned over and over and over again. They didn't let her help this patient until they saw some sort of proof. And I don't know how many of you carry a wallet-sized copy of your medical license in your pocket. I would imagine not many of you. But unfortunately, Dr. Fatima Cody knew to do this because it was almost like she expected something like this to happen. And it's really not a surprise that she had almost kind of planned ahead for this, because if you Google doctor, you don't see Dr. Cody represented, right? Dr. Nick Gordon can also testify to gender bias. As a trans man, 10 years ago, he was constantly mistaken for a nurse. And now, since medically transitioning, now that he's never mistaken for a nurse. He's always Dr. Gordon. So if every community and everyone's listened to differently based off of demographic, then what makes a community? I think about shared identity. I think about how parents going to a school board meeting to rally around their kids needing special education, how everyone in that moment is all just a parent, right? That's their kind of community identity. They want to save their kids' special education program. I think about shared belief systems. I think about people who are anti-vax and people who are pro-vax. Hopefully everyone in this room got their flu shot this year. If not, go like right after this talk and get your flu shot. I'll pay for it. And the reasons why people believe what they do, and how the kind of dialogue that we have based off of our belief systems form, and how that makes community. And I think about common location. I think about how a Muslim woman wearing hijab in the Deep South would most likely have a very different experience than her counterpart living in Dearborn, Michigan, and how communities treat each other and how they support each other based off of where they live. And then I think about similar experience. Seattle Children's has this kind of shared bike program, or this kind of like free rent-a-bike program, and a lot of folks will bike to work because of it. And so a lot of providers will then come in and they'll say, "Oh my gosh, it rained this morning. I have to change my clothes. I didn't expect this." And I'm thinking, like, of course it rained. You live in Seattle. But so it creates this kind of like this shared experience and this community dialogue when they're walking down the hallway talking about their commute to work. Personally, I'm never going to take part in this program because I don't want to get rained on the way to work. But I think it's great for people who participate in this kind of community experience. And then perhaps, to me, the most important part of creating community is how we're socialized, this kind of socialization. So I distinctly remember the moment when I realized that I was socialized differently than the way that the world sees me now. It was a couple years ago, and I was sitting at an airport waiting for a flight, and a mom and her probably like 6 or 8 year old kiddo walked by. And it was about 10 in the morning. So it was a little too early for ice cream for me, but not for this kiddo. And so they were eating this like chocolate ice cream cone, and it was dripping all over their face, all over their shirt. It was the cutest thing. And so I just had this huge smile on my face looking at this kid. And then their mom made eye contact with me and noticed that I was smiling at her kid. And she had the most fearful look on her face that I had ever seen. And she immediately took her kid from the one side of her body to the other, and they moved to another area of the airport. And I had never had that experience before. And immediately I wondered, did I scare them? What did I do? Was I scaring other parents? Why did this happen? And so, of course, I made it all about me, right? And so I love kids. I work with kids. I've always worked with kids growing up. And what I love about kids is that they always want to get to the truth of the matter. They never stop until they get an answer. And so that doesn't stop when we get older, right? We're kind of like nosy individuals. We always kind of want to know what's going on with other people. And the same can be said about our colleagues, about our peers. And so, now, over the past couple of years especially, folks always kind of ask me, do you have a partner? Who'd you spend time this weekend? It's often kind of assumed that I'm a cis gay man. And I love that my queerness is so visible to other people. But it also is this kind of touch and go of, what does that mean to other people when they see my queerness, and how do they feel about that? And I bring this up because I imagine that mom that I saw in the airport, that she either thought that I was a scary man, a stranger looking at her child, that I was a gay man and that she didn't like that, or that I looked so tired that it was scary. And regardless of the reason why, of course I don't blame her for protecting her child, right? But I have this gender history and was socialized in a way that socialized me in a way where if I previously hadn't smiled at her kid, that I probably would have gotten a strange look, right? I love this giant ice cream cone. Sorry, I didn't show you the ice cream cone sooner. But how we're socialized impacts so much of how we interact with the world in public spaces, whether that is here in the hospital, whether that is out and about waiting at the bus stop. I know so oftentimes now, when I'm going on rounds and folks are introducing themselves to me, men always introduce themselves to me and they don't introduce themselves to the women who I'm with. And there's this ridiculous sexism and this culture of sexism that is just so ingrained in us now that we all need to continue to disrupt. So if everyone gets socialized differently, and that kind of builds into how we interact with other people, then who decides, how we define a community? Who gets to kind of make that decision? Well, I say that we do, right? And for so long, trans folks have had to kind of turn inwards for healthcare. And recently, I think, especially recently, been doing a lot of kind of inflection on who trans folks have been able to kind of look to in history for trans health experiences. And we've had a lot of really great folks over the years who kind of protected us. So one of my earliest kind of favorite stories about trans health and medical history is that of Dr. Michael Dillon and Roberta Cowell. So Dr. Michael Dillon was a trans man in medical school when he met Roberta Cowell, a trans woman. And so Roberta had heard about Michael, and she knew that he had some medical skills, and so she wondered, no one has been willing to perform the surgery that I need. Is this something that you would be willing to do? And so as a fellow member of the trans community, Michael said, okay, I'll teach myself how to do it. I'll do it for you. I'll risk my medical license and I'll perform the surgery for you. And so he did. And this is one of my favorite examples about trans medical history because it just kind of exemplifies what the trans community is willing to do when no one else will help us. Then I fast forward decades and I think about Dr. Ben Barres, who died just last year, who was the former chair of the neurobiology department at Stanford. And he is another great example of kind of gender bias in action, how after medically transitioning, people would always come up to him and say, wow, your research is so much better than your sister's. And I just can't believe the difference, you're so much smarter, and just how ridiculous that is, right? Just blatant sexism was literally the exact same research. And so I think about how in modern day trans health research kind of plays out and looks like, and a lot of that is really kind of these peer-to-peer conversations through social media. And I think about how the trans community kind of sustains itself through support groups online and through tweets and through YouTube videos, and how this kind of knowledge kind of maintains itself and spreads. But I also think about how trans folks are not going to be able to kind of maintain this information forever, right? And we're going to need folks in the medical community to help us and to continue to be providers who are knowledgeable about our community. And so when I think about that, I think about, okay, well, what's kind of like the current state of the union with trans health and medical education, and what can we do to improve that? So currently, 97% of medical residents believe that trans health is important to their practice. So yes, that's great. However, only 19% of residents have ever received any training in working with the trans community. That is just wild to me. And those who have had any sort of training have only had 2 hours worth. And those 2 hours are generally kind of one-time attitude-based interventions that show significant short-term improvement, but really lack the long-term interventions and skills-based training. And so because we have this huge gap in medical education, it's this kind of inter-community knowledge that we need to continue to maintain until we can kind of close those gaps. So I don't know who here is familiar with Surgeon Scorecard or ProPublica, but I think of Surgeon Scorecard as an excellent example of something that is currently in place, and something that's kind of an example that we could kind of look to as something future to build for the trans community. So a Surgeon Scorecard was created within the past couple of years as this kind of database that looked to kind of compile the error rates and the complications of over 16,000 surgeons, which I know might make some people nervous hearing that. But so compiled the error rates of 16,000 surgeons, and it looked at the 8 most common Medicare procedures, and it adjusted for patient age and health and hospital quality. And it looked at these procedures that, are scheduled in advance, and patients have to be, in generally good health to have them. So kind of like gender-affirming surgeries for trans people. And what it did is create this system for trans folks to look at this data to really create, or not for trans folks, but in my mind, this kind of future vision that I have, is create a system for folks to look and make much better informed decisions when selecting a surgeon. And I see this as kind of a possibility for something in the future that trans folks could look to, because when you don't really have data to go off of, and when you don't have this information, it's not really surprising that trans folks don't trust a medical system when the research isn't available to them. So I know some people might be thinking, we have a gender clinic. Isn't that enough? And having a gender clinic is a great start. It certainly is a great start, but it's just the beginning. It's just the beginning. And I think about how when I go to look for a surgeon, when other folks go to look for a provider, one of the first things I do is go on their webpage and I go to see, do they have LGBT anywhere? Do they have the word transgender? Is there a rainbow anywhere in sight? Are there photos of community members? Like, I'm out there searching. I'm really digging into their webpage. And I'm really kind of looking to see, if this person, is willing to kind of support me in public, If not, then they're not really giving me any indication that they're willing to support me in my community in private. And what I also think about is how, especially right now, even in the past month alone, when we have these different memos coming out and we have these other concerns about policy rollbacks, I think about how folks like Kaiser within the past week came out and made a public statement about how, even if federal requirements are removed for about care for trans folks, that they would still continue to provide trans health care. And that really makes a statement, and that really tells trans people, we will support you no matter what. You can trust us, and you can rely on us to provide care for you. Because it's one thing to have a gender clinic, and it's another thing to emphatically state, yes, we are here for you. Yes, you can trust us over and over again publicly. And I think about how this plays out on our websites as well. And so I did just kind of a quick search on Mayo's website, and I had a conversation earlier today about how this search might go on other websites and looking elsewhere on internal servers for Mayo's. But I did a search for the word transgender on the Office of Health Disparities Research webpage, and I thought about how 0 results came up, and how the tagline is, addressing health disparities is our priority. And so when I saw 0 results come up, I thought, does that mean that the health disparities of transgender patients are not Mayo Clinic's priorities? And that really kind of got me thinking about, okay, so if there isn't trans health research going on right now, then what can we do to change that, right? Because that doesn't mean that that's something stagnant and that we can't change. And then I thought about how if we want to do research, and if we're going to do research, then we can't just do research to do research, right? We have to do it the right way. And so what doing trans health research the right way is looking at what are patients being concerned about in research outcomes. That means involving patients from the start in the design methodologies. That means asking the trans community, what photos do you want to see on the recruiting flyers? That means what language should we use and what language should we not be using? And then I think about what are opportunities that we could change here at Mayo, right? So the general error rates for trans-affirming surgeries, gender-affirming surgeries are studied, but there's no transparency required from individual surgeons to disclose to patients or the public. And there's no standard method for measuring error rates for transition-related surgeries. And there's no central database for surgeons for transition-related surgeries, and there's no way to compare error rates between different surgeons. And so I think, how are we supposed to encourage patients to be informed in our care and to be autonomous individuals when we don't have that data to look to? So without that data to look to, I think then we have to circle back around to inter-community knowledge, and we look to community resources like the support group Toolshed in New York that kind of facilitate these conversations and ask folks to share their knowledge with their surgical outcomes and the data that they've collected kind of experientially. But that's really not a great platform to have when that's the only data you have available to you. So as providers serving the transgender community, we have to assume that there's an expectation that we're going to mess up because someone already has, right? So we have to use this trauma-informed approach where we're acknowledging that people bring stuff into the room and that we bring our own stuff into the room too. So there's a hashtag that went around Twitter, in recent years called #TransHealthFail. And what it did is it allowed folks to kind of share their kind of like deepest, darkest, like worst healthcare experiences. And what it did is it kind of like brought out the worst in healthcare and then almost allowed people to do something about it, to rebuild a way around it. And so as people started to come out and share all the things that went poorly, it allowed the trans community to build a solution to it on our own. So all of these databases started popping up. We had My Trans Health was the first one to come up, and it was the reason why the hashtag Trans Health Fail was created in the first place. And so what these different databases are, some of them are across the country, some of them are state-specific, and they allow you to kind of go in and select these different drop-down options of, I need an endocrinologist who speaks Spanish, who is in Phoenix, Arizona, and uses the informed consent model and has women providers and like these incredibly specific criteria. And then it will spit out all the different providers who meet those criteria, and it'll tell you who they are. And the reason why they're in these databases is because they've been pre-vetted by community members. And so these databases are recognized, and they're starting to be more and more recognized by surgeons as well as a kind of way to show that, yes, we as providers who are not members of the transgender community trust the knowledge that the trans community is bringing, and we would like to be a part of this. And there are separate databases that aren't listed on this slide that also function on image and aesthetic alone. And so those slides or those databases focus on the aesthetics, and so they are post-operative results that focus more on post-op sensation, satisfaction with image, and all of these different things, and also share price points to find different surgeons. And so the community almost kind of functions as this never-ending qualitative research project. And we have to think about what happens when someone wants to rebuild trust as an institution. So I think about Johns Hopkins as an example, which historically has had a lot of missteps as it relates to race and as it relates to the trans community as well. They were the first institution to offer gender-affirming surgeries. They opened their doors back in 1966, and then they promptly closed them in 1979 after some inter-institution disagreements about whether or not they should be offering these surgeries. And so in recent years, they realized, we should probably start offering these again. And so what they did is they opened their doors again, and they knew that they were going to have a hard time reconnecting with the community. And they did a lot of community outreach, and they made sure that this time around they were going to do things right. And so doing things right for them meant making sure that this was a community-run clinic, and so that this was by the community for the community. And so what that meant is that Paula Nera runs the clinic, and so she's a trans woman, and she is a nurse, and she's a lawyer, and she is a Navy veteran, and so she is highly qualified to run this clinic. And what this now looks like after opening its doors is that Johns Hopkins has one of the most well-respected surgeons for performing phalloplasty, and community members actually do want to go to Johns Hopkins as their clinic and see it as a source of trust and information. But this process was a long time coming. But even if we are knowledgeable about trans health, even if we do get our patients' pronouns right, even if we get their name right, even if we are continuing to do this process and this work, more likely than not, there is going to be some sort of systems error, and so we can blame MyChart or we can blame Epic, and we're going to get someone's name wrong, or we're going to get their pronoun wrong, and that's just going to happen, right? And when that does happen, I'm really glad that we are going to have each other as a resource and to continue this conversation, or to talk together today. Thank you.
Thank you for a wonderful start. And for those of you who are watching from different locations, my pager is 47055, so if you want to send a text page with a question for Charlie, I'll try to relay it. So I'd invite anyone in the audience with questions or comments. I'm sure there must be several. We've got some people with microphones who are maneuvering around. While we're waiting with that, I was intrigued by the observation that socialization starts early. And a few years ago at Transform, George Halverson from Kaiser talked to us about the importance of a healthcare delivery system recognizing its important role in creating a community and nurturing that community. What advice would you give us for doing a better job in that regard?
You know, this is something that I talked about a little bit this morning with some other folks, and I think one of the most important things that that we have to consider when we're reaching out to any community or when we're trying to work with any community is really trying to find out who are the local organizations and who are the trusted resources for that community, whether that's here in Minnesota or whether that's nationally, right? Because those are the groups and those are the resources who are going to know best what the priorities of those groups are. So when we reach out to whether it's a national organization, whether it's a local group, and we are able to figure out what those priorities are, then we're no longer doing the guesswork of what we assume people might want. We're able to find out what they actually want as a fact.
So are there questions? I thought I saw a hand up over here somewhere. So you also talked about bias early on, and you actually identified gender bias, but reflected that there are many other kinds of bias. How should we work on trying to make it easier for people working within Mayo to recognize those biases when they occur? It seems to me we miss an awful lot.
Yeah, that's a great point. Yeah, I think so often bias is really easy to overlook because it's really hard to give up power when we are in positions of authority or when we are in powerful positions. And so I think about what bias can look like and what these powerful positions can look like is, what research gets funded and what research doesn't get funded. And so thinking about, if we have research that is only on, white men and long-term health outcomes of prostate cancer versus looking at preterm birth and early death concerns for women of color and how one has more funding than the other, and thinking about who I guess just thinking about that, thinking about who is a higher up position in meetings, who is running the meetings and who isn't, who has which group has more men and which group has more women, which group is an all-white committee, which group actually has people of color on it. And when we notice these things, actually speaking up and actually kind of being willing to give up power too. I think one of the hardest things to do when we are in a position of power is to give that up. And so, you and I sitting here, two white men, and thinking about what might this conversation look like in the future. Would this conversation look like two trans women of color having this conversation instead, and thinking about who are the folks who are more marginalized versus you and I who have, arguably the most privilege in the entire room.
Dr. Hayes.
Yep. So thank you for your provocative talk about what we need to do. And I wanted to go back to medical education, whether it's in our medical school or residency programs. One of the challenges we have is we take such a systems approach. So we talk about the GI system and the cardiovascular system or talk about microbiology, often in isolation, instead of the holistic person. It's not until you're on the wards and doing rotations. So I think we need to do better for women's health, for other things, to embed it throughout our curriculum. So I'd love your thoughts on that, but also, is there anyone who is doing it well in terms of transgender health for training of our future nurses and doctors?
Yeah, that's an excellent point. So I will answer the second question first. And so I think about the work that that UCSF is doing. I think about so UCSF is kind of if you go on their website, if you Google UCSF Transgender Center of Excellence, oftentimes they're who folks will look to for kind of guidelines or for kind of recommendations for ways to handle particular conversations or not necessarily standards of care, but similar. And I think about the ways in which they're having that center of excellence there and having a gender clinic there as well that also sees youth, allows for them to have those conversations. And then when I think about how we embed medical education for trans folks throughout medical education, I think about how whether that's in gyno rotations and thinking about, just asking folks, how do you talk about your body, and not just assuming that, and thinking about how trans men have babies, and thinking about how we think about HIV and AIDS, and we think about trans women of color having higher risks for that, and we think about how we just talk about in every single kind of checkpoint of education. We think about how do trans people factor in this, and not just thinking about gender in a binary, because gender is this kind of spectrum, or at least I would like to think so. And I think queer folks as well, not just thinking about this is how we talk about women's health, and this is how we talk about men's health, but thinking about how this looks across gender, across queerness and sexual orientation. But these are ongoing conversations that I think UCSF does a really nice job of, and that I also think Kaiser. There are some working groups at Kaiser that Dr. Sam Chang, who is a psychiatrist there, is doing a really nice job with as well. Yeah.
Allison Matthews.
Hi, thanks for coming. One of the things, I work with the innovation and design team, and we are often thinking of kind of future concepts. Yeah. And so one of the things that's always difficult is think about how do we get from where we are today to where we're going to be. And of course, the future solution is to have people have better education. But how can you support teams as they try to be vulnerable with their trans patients in a way that shows them, maybe I don't know everything that I need to know to care for you, but how can we still work together to have a productive interaction?
Yeah. I think about, actually an experience that I had with a Mayo Clinic physician in Arizona, and one of the things that I really, really appreciated about my kind of care with him was that. He had this kind of folder that was his kind of like trans patients folder, and so it was funny. He would like wheel his like laptop cart in, and he would have his like trans health folder, and so each time he and I saw each other, I was generally kind of providing him information, and there was always kind of this learning curve between the two of us, but he was always so excited and so willing to learn, and I would bring up talking points or things that I wanted to know more about that he might not necessarily have more information about, but he would say, I'm not sure, let me find out and get back to you. And we would kind of message back and forth on the patient portal, and I would send him articles and he would send me articles, and it was kind of this ongoing relationship where we were learning together. And I think there's so much power in saying, and so much importance as well in saying, I don't know, but let me find out, rather than pretending to know and giving someone bad medical advice and actually doing harm long term. Because I've also seen that happen in the community where providers, really do mean their best and really do want to help their trans patient, but might not have the expertise in providing the right hormone dosage or doing those things, and long term it ends up being not so great of an outcome. So I think really just being honest and saying I might not have the expertise in this, but I'm learning, and it would be great if we could learn together.
Here in the front.
There we go. So you had a slide in there, I don't remember the words exactly, but it said something like if there's no public kind of explicit affirmation, you can't believe that you'll have that affirmation in private. And I think that can sometimes be surprising that public, clear, explicit affirmation is necessary to be able to trust an individual provider who you're seeing. So I'm wondering if you can talk a little bit more about that and why a community would need kind of that external, explicit affirmation to trust even an individual provider that they're sitting across from.
Yeah. I think so often folks have been harmed by previous providers, and so I can't remember if the statistic is either 1 in 3 or 1 in 4 trans patients have had a negative experience when going to see a healthcare provider, and so whether that is refusal of treatment, whether that is verbal harassment, whether that is physical abuse even, and so with that kind of number in mind, knowing that either one of you 3 or one of you 4 going to the doctor kind of already has this in mind. I might be attacked at this appointment, or I might have this really not so great experience before even going. I think there's something to be said about explicitly knowing, okay, this person has experience in working with me, this person has experience in working with my community, they know how to care for me already, rather than going in with the anxiety threshold being up here. I think there's something to be said about just knowing before even going to the appointment that it's someone you can trust.
In the back.
Thank you. I work for Ask Mayo Expert, which is an internet resource that's created by Mayo experts for Mayo clinicians. And I just want to let you know that we have information on Ask Mayo Expert about transgender health. And there's also a tab at the top that says experts, and that gives you contact information to people who are experts in transgender health at Mayo. So I hope that's a resource that you will use. Thank you.
Thanks for sharing that.
Yeah, that actually is great to know in terms of where resources are. I'm intrigued. When you showed some of the examples of how not to do it from TransFail Health, is there anything that is available to show how to do it? Or other than the Johns Hopkins example, what are some of the best ways to deliver care, true care to people who need it in the context of their transgen?
Yeah. So I think about how something as simple as introducing yourself, saying, "Hi, my name is Charlie. My pronouns are they or he," and just kind of doing that while you continue to flow into your conversation, and not kind of stopping and making it this uncomfortable thing. And I know a lot of folks are uncomfortable with kind of introducing themselves with their pronouns to every single person, and they might think, okay, maybe I would do this to a teenager, but I don't know if I would do this to my 80-year-old Army veteran patient. I've certainly heard that before. And I think there's also something to be said about folks who aren't as comfortable verbally saying their pronouns to have a kind of like a pin or a clip that has that on their badge. I know that my badge from Seattle Children's is one that I got from their gender clinic, and it has he, him on it, and so I just kind of clip that onto my belt. And so then I hope that whenever I interact with kids, they see that and they know, oh, okay, these are his pronouns, and then I can tell him mine if I want to. And so there are like little things like pronouns like that. And I also think about assumptions and not making assumptions about what people want to be called, and thinking about how people oftentimes, especially when it comes to examinations, kind of make assumptions about body parts, and instead asking, how do you call, like, what do you call this body part? Or instead of assuming what kinds of partners people have, saying, do you have any partners? What kind of partners are they? And instead just kind of asking open-ended questions instead, using this or is this like motivational interviewing, open-ended questions kind of approach. And so really kind of taking the like inner social worker in yourself out and using that in the moment. Yeah.
So there's a question over here, I thought. Go ahead.
Hi, Charlie. My question really kind of goes to the mental health status of transgender. And as we know, there's a very high suicide attempt and a rate amongst this community. And I'm wondering what your thoughts are on making that better for the trans community and what we can do as being Mayo Clinic, what specialties we can offer to these individuals.
Yeah, that's an excellent question. I think a lot of times when we talk about that really high number of suicide attempt rates, we don't always talk about the contextual factors that contribute to that. And so typically when people say, the trans community has this really high suicide rate, we don't always mention with the caveat of when we kind of came to this number in the research, we came to it and found that this number has to do with familial rejection, with rates of homelessness, with school bullying, with difficulty finding employment. And so I think we always kind of forget that it's not that being trans leads to mental health outcomes, poor mental health outcomes and suicide rates. It's because of these social factors that then, I would imagine if any of us in this room were homeless and had difficulty finding a job and were rejected by our families and were bullied at work, would not feel so great about ourselves, right? And so I think it's always kind of keeping that context in mind. And so then I think about, what are the roles of the social workers here? And then how can the social workers kind of help with that housing and with kind of school supports? Or I imagine there aren't, there are kiddos who are seen here, right? But thinking about, how can we help with housing? How can we help with job support? And kind of screening for that too when folks are coming in and seeing and thinking about what are kind of the outside resources that we can provide.
Right. Go ahead, please.
Yeah, since you do a lot of work with children, just kind of what would you recommend as ways to talk to children, and at what age is that appropriate to have those kinds of conversations?
Yeah, that's a great question. I think a lot of people get kind of uncomfortable about the kid's too young to hear about this or talk about this, and then eventually there's kind of oh well, now they're kind of too old, and so I think about we start to kind of understand and form our sense of gender between the ages of 3 and 5, and then talking about what transgender is kind of this other concept when people I think have conversations about gender. I think most people think about it in that regard. But I think there are different ways to talk about being trans, and so some people might say, I think a lot of people buy into this kind of common narrative of born in the wrong body, which is kind of a media public way of talking about being trans, which is not always how people feel. But some people might talk about how being trans, your friends, Sarah at school, people thought that Sarah was a boy, but Sarah is actually a girl. And so we call Sarah Sarah, and we say she and hers, just like how we call you she and her and hers, and just keeping it really simple and age developmentally appropriate, because just how we talk about other really kind of bigger topics well, I don't know. I was going to explain end of life for kids and other things, but just we always keep everything developmentally appropriate, right? And so I think it all just depends on how mature the kid is too, and just thinking about developmentally appropriate conversations. Yeah.
Other questions? Charlie, in the Kern Center, we do a lot of health services research. From your experience with the TransYouth Project and what you referenced on the slide about the right way to do things using the Corey model, Could you tell us what we should be doing better that way?
Yeah. And so I'm glad you brought that up in that regard, because I have a little bit of a correction. So I am not like the director of TYP. I did not start the TransYouth Project by any means. That is Dr. Christina Olson. But so TYP, the TransYouth Project, enrolls kiddos ages 3 to 12, and then the plan is to follow them for 20 years. And so right now, what that looks like is we have 300 kiddos in the study in 45 states and a couple provinces in Canada. And so we visit every like 1 to 2 years, and then follow-up surveys, and really kind of getting a sense of mental health and kind of social experiences. And so far, what's been found is that kind of speaking to this like suicide rate concern, is that trans kids and gender nonconforming kids, there's kind of two different cohorts, have mental health that is really on track with their non-trans peers, with similar rates of anxiety and only or similar rates of depression and only slightly elevated rates of anxiety that are still below clinical levels. And so that is really promising, I think. And we also have to think about how the kids in the study are, of course, kind of living in affirming or at least somewhat affirming households in order to be in this study. But that, I think, also just speaks to what living in a supportive environment can do for youth, right?
We have time for one last question.
My name's Corey. I'm a pediatric nurse. I just have a quick question. In your travels or your teachings in social work, have you found merit to like the safe spaces, the emblems they used to put up like in doorways and stuff like that? Because kind of going off of your, like safe environment for kids, something just to show, hey, like when I was growing up, I didn't even know who I could talk to. So just seeing something like that when I would go to schools for activities was like enlightening for me. Do you still see that, or know if there's merit to that program?
I think I can't really speak to the kind of safe space like stickers. I know exactly what you're talking about. However, I would imagine that just kind of having that visual and those kind of teacher supports are incredibly affirming for whoever is going to see them, given that we know that having at least one supportive adult in a queer child's life decreases their chance of their likelihood of committing suicide by the statistic is escaping me, but it does significantly decrease that attempt at suicide. And so I would say that having that kind of just having that sticker or having that sign up does hopefully signify that whoever has that up is a person that they can talk to. So I would imagine that in that regard, it is a program that is still kind of worthwhile, or at least having some sort of rainbow sticker or some sort of flag.
Great. I want to thank all of you for coming today and your participation in the conversation, and especially Charlie, thank you for coming to Mayo Clinic. This was a wonderful day. Best wishes in your studies and your research. Thanks, everybody. Good day.